Well, I want to start off by welcoming everybody and thanking you for taking time out of your Saturday morning to be here. It's my job to be here, but it's not yours, and I thank you for being here. I want to introduce people that are here this morning. This is my seatmate, and he's my seatmate this morning, except he's on my left instead of my right today. Representative Bruce Westerman, man that I have utmost confidence in as a member of the legislature and as a friend. Character and integrity is just exemplary, and he gave up some turkey hunting with his son this morning to be here on his one day off from the week schedule. So I really appreciate him taking time to be here. On my right is Surgeon General of the State of Arkansas, Dr. Joe Thompson. He drove all the way from Little Rock today to be with us, and while he was blessed with some beauty, he also gave up his Saturday to join us, and I'm very appreciative of him taking the time to do that and to try to help us understand where we're going with this. And with that, I'll kind of lay out what we're planning for an agenda today. I'll ask Surgeon General Thompson to kind of present the positive aspects of what's now known as the Arkansas plan and maybe give a little bit of an overview. Representative Westerman has an alternative plan. I think he will walk through that with us and also explain some of the flaws in the Arkansas plan and why, at least at this point, he doesn't believe it's a good idea. And the reason that I asked the Speaker of the House to delay the vote till Monday is at this point, for the first time probably in my entire life, I really am completely undecided on something. I've struggled with this decision more, and I think Phyllis would attest that we've had a lot of phone conversations as I've struggled to try to find the right thing to do here. There is no right answer. I want to make that clear. I really don't believe there's a right answer here. There are only less wrong answers. We've been put in the situation by the folks in Washington, D.C. with the PPACA that ties our hands. We have very few options with what we can do to maintain our healthcare system and maintain some semblance of a free market along with it. I know that folks in this room are on all different sides of political policy. I just want to say this. When I ran for office this last election, there was a pretty clear choice with regard to Medicaid expansion, and that choice was, at that point, are we going to expand Medicaid or are we not going to? My opponent in that election stood in front of all of you and said he wanted to expand Medicaid. I told you I didn't. 65% of you voted for me. I have to assume that means that most of you at that point didn't want to expand Medicaid. Having said that, that's not exactly what we're dealing with today. The game has changed because of the shift in power in the legislature, because of a lot of folks working very hard. Representative Westerman, Dr. Thompson, and 4 or 5 other members of the legislature have worked very hard on developing this plan, and it's within the last few days that it just couldn't come together to the point that Representative Westerman felt comfortable staying with that. I think he'll elaborate on that a little more. Dr. Thompson obviously is still very much for it. There are people of goodwill who are very bright, solid, consistent people on both sides of this issue, and it's to the point now that I can't sit in front of you and tell you that there is anything that is a better fiscal option or a better logical option. We really are almost into the weeds to the point of dealing with moral decisions, and it's usually difficult to make good law based on moral decision making. And I really am very uncomfortable being in that position. So with that, I think I'm going to go ahead and let Dr. Thompson kind of present what he believes the advantages of this are. After that, we'll let Representative Westerman kind of go through that, and then I think we'll, just as a 3-person panel here, we'll open it up for your questions or maybe what any of y'all feel like you have to add to that discussion. So with that, Dr. Thompson.
Thanks, Nate. And I just, before I start, I want to just commend both Representative Westerman, Representative Bell, all the other guys that have been sent, guys and gals that have been sent to Little Rock. They do an incredible job of bringing all the interests of the state under the dome of the Capitol to try to figure out where the path for the state should be. They work hard, long hours, long drives, And I think you can be proud of who you sent over there. They've done very, very well over the last 3 months, and I'm sure will continue to do so over the coming years, regardless of what the decisions are here. I'm not a politician. I'm a pediatrician. I've ended up having the opportunity to serve 2 governors, first Governor Huckabee and second Governor Beebe, as their lead advisor on healthcare issues. I don't run the health department. I don't run the Medicaid program. I don't run any state programs. I have a Center for Health Improvement. You'll see some of the information. And let me start from where I am. We've got folks that are not being able to get care that they need. That's resulting in them having disabilities or untreated conditions that costing them their lives every day. It's a 55, 60-year-old person who's having chest pain, but he blows it off wanting it to be indigestion, but it ends up being a heart attack, and you're in the emergency room tonight, and you know he's not able to go back tomorrow. We have 250,000 folks that this decision will help. We have about 550 or 600,000 folks in the state that have no health insurance coverage whatsoever. That's 25% of every 19 to 64-year-old has no health insurance coverage. It's not that they're healthy. 50% of them have a chronic condition. They're going to end up in the emergency room or the hospital sometime, but they don't have a way to pay for their care. And that has made, over the last 10 years, our health care system in this state become less and less stable. Now, we all want to have our hospital there. We want to have our doctors there. We want to be able to be taken care of. But the balance sheet isn't working anymore. And it wasn't working nationwide. And part of that is because we hadn't got control of our costs in Congress, and we're spending too much, and we're going, spinning out of control. But the Affordable Care Act, at least for our state, spun us even a little more into the problem. Because what it did is when Congress passed it, they said every state is going to expand Medicaid, so let's take some money out of the state to help pay for that. And then the Supreme Court came along and said, no, you can't tell states they have to expand Medicaid. States have to make that choice, and that's the choice that's before these guys this week. But they didn't say states can voluntarily not pay the taxes or not have the Medicare cuts that are going into effect on the hospitals, or not have the employer penalties that are going to go into effect if we don't expand and offer coverage. So all 3 of those things are going to happen. And you've got a tan sheet in the back of your packet here that Nate put together that has the 3 big negatives that are already going into effect. Your taxes have gone up on your Medicare payroll tax because of the Affordable Care Act. Your hospital has already been cut in the payments that it's getting for when it takes care of Medicare beneficiaries, and Tim may want to relay what that is in a little bit. Next January, if your employers don't offer health insurance coverage, they're going to have a penalty that if the legislators decide to take this private option will be lessened. That penalty will be blunted. So all those negatives of taking money out that Congress thought was going to come back because they were going to force us to expand Medicaid, now it's our choice of whether we expand Medicaid to grab that federal money and bring it back into the state. Now, with Representative Westerman and Representative Bell being forced to expand Medicaid in the old way, which is what Congress intended, really wasn't what we wanted to do. It's not what we've ever done. We've had some success using the federal government through Our Kids First. We also have the AR Health Networks program where we partnered with small business, but people paid part of their share going along. But otherwise, we have actually not used the Medicaid program like other states have to cover their adults. In fact, in our state, to be on Medicaid as an adult, you have to be a parent of a child that's on Our Kids. You have to make less than $6,000 a year, and you have to have less than $2,000 in assets. Okay, so you really, if you're making minimum wage, you're not eligible for Medicaid. If you're 55 and you have a car wreck and you're in the hospital for 6 months, you're not eligible for Medicaid. Medicaid is not going to help you pay those bills. Now, the other way that people can they can come in by being declared disabled and get on Medicaid in a different way, but we really haven't used the Medicaid program, so we are at the very bottom of all the states in drawing federal funds in to use them. Wisconsin covers a parent if they make up to $35,000 a year. They're bringing money in from the federal government to help pay for insurance for working parents up to $35,000, no asset test. We're at $6,000. So from my perspective as a doc giving advice to our leadership, it's not fair how different states are using this program. But we didn't want to fall into the trap of the traditional Medicaid program. So the leadership in the Senate and the House challenged the governor to go back to the secretary and say, can we do it a different way? And we went, we worked through a program plan, concept, and the governor met with the secretary in late February, and we put the plan in front of her team. And as you may know, the Affordable Care Act is going to set up a health insurance exchange where people that aren't on Medicaid at higher incomes can go and shop for their health insurance, kind of like you shop for airplane tickets now on the computer. Used to you had to go to a travel agent to get your airplane ticket. Now you can go and buy stuff on the computer. That's what the health insurance exchange is going to be, private insurance by private plans with cost sharing and co-payments and those things. And we asked the secretary, can we take the federal money and not expand Medicaid and buy it for folks on the private health insurance from the private companies, essentially privatize, if you will, the low-income purchase of health insurance. People have to pay part of it through co-payments and co-insurance. It's not free care given away. And that's what she said yes to. Now, that then put the ball back in our court to say, does our General Assembly want us to do that? And that's the discussion that's in front of the General Assembly now, is to not set up a Medicaid program with a Medicaid card, but to help people be able to get private insurance through private companies in the Arkansas health insurance marketplace. Now, I want to come back just a little bit to who this is. These are people that are making less than $15,000 a year. That $15,000 is about 130% of the poverty level. These are folks that probably cannot afford, I mean, an average health insurance policy for a family of four in the state's $12,000 a year now. So they're not going to have health insurance. They're going to need health care. When they go and get health care, the hospital's going to give it, but they're still going to have to balance their sheet. So that comes back for those of us who are now buying health care. Our premiums go up to help pay for the uncompensated care. So this is a way to take that away. And over time, we believe that actually people will be able to work themselves up out of poverty because they won't have a reason to not work harder and make more money to stay on the Medicaid program. Right now, we have folks that don't want to make more money because they'll lose their health care benefit. The way the health insurance exchange works, the more money you make, you keep your health benefit, you just owe a little more of the premium cost. And so what we're hoping to do is put low-income people into the private health insurance market, teach them how to use health insurance, and not have a cliff that keeps them from wanting to increase their income and better themselves and work up out of poverty into the middle income. That's the strategy. I think it is an innovative policy. We think that the projections are that of the current Medicaid folks, that we'd have about 200,000 fewer of them in 2 years. They would move over onto this private option. For our providers, it gets payments to the hospital, payments to the doctors, payments to the pharmacies. The other thing that I think is critically important is the number one cause of bankruptcy in the state of Arkansas is unpaid medical bills. When you go, and no offense, Tim, at the hospital, but when you go to some hospitals, if you don't have an insurance card, what do they ask you for? Well, do you have a credit card? When you have a $6,000 hospital bill, the credit card company is not as forgiving as the hospital at the end of the month. They're going to put another 18% on top of that, and 18%, and suddenly you're cycling into a bankruptcy. And that's why the number one cause of bankruptcies, it's not just the doctors and the hospitals that want to help. It's the people who have a loan at the bank, an auto loan, a furniture loan, you're buying on the margin. All of these things are starting to have an impact, particularly on rural Arkansas. Let me just close, last thing I'll say. Well, I said 25% of Arkansans 19 to 64 years old don't have insurance. It is much higher in rural Arkansas. Most of us get our insurance from our jobs. For you to get insurance from your jobs, you usually have to work for a large company or have a higher salary. And the uninsured rates in rural Arkansas, particularly even over here in western parts of Arkansas, are sometimes 30, 35% of the 19 to 64-year-olds. And that starts to affect your ability to attract doctors, others out. If I was a graduating family practice resident at UAMS, why would I move to a community who had an uninsurance rate of 35%, where 1 in 3 people aren't going to be able to pay me? I'd stay in Little Rock, which is what we see when we have too many doctors in Little Rock, and we don't have enough doctors out here in the rural parts of the state. So with that, let me close. I look forward to having conversations. It is a cost. You can't expand insurance coverage to 250,000 people without somebody paying for it. But I think we've already paid for it or are paying for it, and it's time for us to pull our money back of what's being taken out.
I want to just interject before we move to Bruce. One of the things that is happening here, and you mentioned the $250,000 figure, but a significant percentage of those people would be covered under the Affordable Care Act through subsidized coverage. I think the number that actually would be left out totally if we did nothing is closer to 90,000. Is that correct?
It's about 130,000.
Okay.
I mean, and let me just say, there's about 70,000 that would have the option to buy. One of the impacts of the private option is that healthier people are probably going to be in that insurance market. And when you have healthier people in, the premiums are lower for those people that are paying their own way. We've always had this issue of people kind of, insurance doesn't work for health care. I want you to think about this just for a little bit. I mean, you don't get to buy car insurance after you have a wreck to get your car fixed. You don't get to buy homeowner's insurance after the tree falls on it to get your roof fixed. But we kind of want you to be able to buy health insurance after you have cancer or a heart attack or something else to take care of your future needs. And we got to figure out how we get everybody insured while they're healthy to keep the premiums affordable for us for when we need it. And I think that's one of the things that we're trying to do here, stabilize that health insurance marketplace.
Now, one more thing that I want to make sure that I'm getting correctly. Currently, as I understand it, about 25% of the insurance premiums that we're paying are essentially subsidizing uncompensated care and uninsured care. Is that a fair assumption?
I don't know the exact percentage, probably depends some on how rich your benefit package is. This is Arnold Schwarzenegger's hidden tax. He said, 5 years ago, $1,600 out of every insurance premium is going to offset those uncompensated care costs. And we know that people that don't have health insurance still use the system. They just don't have a way to pay for the use of that system, and that's where then the providers have to turn around and charge more for that uncovered care to stay in business.
I'm going to go ahead and let Representative Westerman present, and then I think we'll have quite a few questions, maybe some internally up here and definitely some from you also.
All right. Well, I appreciate the opportunity to be here in Mena, to be with my seatmate Nate Bell and all you fine people and Dr. Thompson. I'm probably sitting on the right place, sitting left of Representative Bell. I sit right of him in the chamber, but he's definitely a conservative, and I'm glad to be here to help answer any questions. He mentioned I've been working on this healthcare issue for quite some time. I had the good fortune of being unopposed in the election. So serving as the minority leader at the time, I spent a lot of time traveling around and trying to help candidates out, but also had the luxury to spend a lot of time looking at policy and policy issues. And we knew this was going to be a huge policy coming up into the session. I will admit, 4 years ago, before I got in the legislature, I didn't know a whole lot about Medicaid, hadn't had a lot of exposure to it, and I hope that after this is all over, I can forget a lot about Medicaid. But I have spent a good part of my life trying to get boned up on the facts on Medicaid. There was a group of us, Senator David Sanders, Senator Jonathan Dismaying, Representative John Burris, and I really, even before the session started, focused in, and we were kind of the core team to come up with some other solution other than just the fee-for-service expansion that's proposed under Obamacare. We spent countless hours meeting with Dr. Thompson, John Seelig, the director of DHS, Andy Allison, the director of Medicaid, and I want to say how much I appreciate those guys. We've got good people in the state of Arkansas working on this issue. My concern is more with the folks in Washington, D.C. that will have a lot of control over what happens here. But as you read the Affordable Care Act, and there seems to be new information that even comes out of it every day, it was Senator Dismaying that discovered that if we didn't expand Medicaid like the President had proposed, the Affordable Care Act is written in such a way that those people that are between 100 and 138% of the poverty level automatically go on to the health insurance exchanges. And I want to stop and back up a little bit on the overall Affordable Care Act. And I want to put it in two different buckets today, because that's kind of what the Supreme Court did in their decision. They said that the states don't have to expand Medicaid, and they left that option to the states. And that's part of Obamacare, or the Affordable Care Act, is this Medicaid expansion. There's another part, and that affects people from 0 to 138% of the poverty level. There's another part that affects people from 138% to 400% of the poverty level. That's the health insurance exchanges that you've been hearing about. Dr. Thompson said there's I believe it was 550 to 600,000 uninsured people in the state of Arkansas right now. About half of those fall in that 138 to 400, and about half of them fall below the 138. So the only decision we have in Arkansas is whether or not to expand Medicaid, and how that affects those 250,000. The official number I believe is 287,000 people below the 138% poverty level. Everybody else up to the 400% will have an opportunity to have health care coverage on the health insurance exchange. So on the baseline, if we do nothing as far as expanding Medicaid, you're already going to be putting the difference between those 550 to 600,000 people on the health insurance exchange. So you got a huge part of those uninsured that are going to have insurance through the health insurance exchange. Because of this nuance in the Affordable Care Act, that if you don't expand, the group from 100 to 138% also go onto the health insurance exchange. And that's approximately 137,000 people. And those numbers vary. You'll hear numbers bounce all around about who's in the 0 to 18%, who's in the 18 to 100%, and who's in the 100 to 138%. And that's part of the issue that I have with where we are right now, is there are so many unknowns about the people that are being covered, the cost, and the long-term effects, that it's hard for me to come to a conclusion on what's the best decision right now. But we do know that if we don't expand Medicaid, everybody from 100 to 400% of the poverty level is going to be on the health insurance exchanges. Then you've got the people from 0 to 18% of the poverty level that could already be on Medicaid that are not on Medicaid right now. And it's projected that 40,000 people that could be getting Medicaid right now will sign up for Medicaid. And you say, well, if they're not on it now, why will they sign up for it? Well, part of the Affordable Care Act is you've got a team, and Dr. Thompson may be able to say more about this. They're called navigators, I believe. They will go around the state. I think of it kind of like as when they do the census, they'll come to your house or wherever, and they'll sign you up. So if you're should be on Medicaid right now and you're not, they'll sign you up, and they call this the woodwork effect. And that may not be a good name, but it's like people will come out of the woodwork to get on Medicaid that should already be on it. So if we don't expand, you've got the people between 18 and 100% of poverty level, and that number's been estimated from 89,000 to, I think you just said 130,000. Mm-hmm. The number I'm showing here is 110,000. So there's somewhere, let's say, 90,000 to 130,000 people that would fall through the cracks on the healthcare system as it is. So
now,
we're
when
going.
you say as it is, that's if we choose not to take any action, that's the group we're talking about.
Right. So we've gone from 550,000 to 600,000 people without any kind of health care or Medicaid coverage, down to 130,000 maximum, I would say. So you have to ask yourself, and I keep hearing this about hospitals are at risk, rural hospitals are going to close, but that's a lot of new money being funneled into the healthcare system that's that's going to be going to health care. And if you look at this handout that I gave you, and you have two handouts. One's the actuarial analysis that's been getting a lot of talk in the news. That is the only third-party independent analysis that's out there right now. And it's just a bunch of tables, and I've tried to summarize that on the top left-hand sheet of this page, what the third-party independent analysis said. And I disagree with some of the things they said, but that's the only independent analysis that we have right now. And they say that under the three options, and status quo is not expanding Medicaid. Where it says expansion, that's President Obama's method of expansion, and then you got the private option. So what the actuaries assumed that was under any three of those scenarios, that woodwork effect, those 40,000 people were going to be put onto Medicaid. And then they didn't break it down from the 18 to 100 or the 100 to 138. They broke it down from the 18 to 138s. And they said there's 247,000 people in that category. And in their analysis, they didn't include in the status quo the 110,000 people that would go on to the exchange between 100 and 138%. And if I need to repeat something, raise your hand, because I've looked at this so much. And I know I'm saying a lot of numbers, but it's complicated, and you have to get down into the weeds to really talk about what's going on here. So we're looking at 287,000 people according to the actuaries. And if we look at the numbers that was in that actuarial analysis, they gave us a 10-year average cost for Arkansas, and they gave us the cost for the federal government. And the line across the top, in status quo or do nothing or no expansion, it says the cost to Arkansas is going to be $1.1 billion over 10 years. If we expand it like President Obama wants to expand it, it's $2 billion over 10 years. And if we expand it under the private option, it's $1.9 billion over 10 years. That's the cost to the state. Now, what the actuaries did is they said, if you expand it under the private option, there are savings you're going to capture. And compared to the status quo, this right-hand column are the savings that they say you're going to, the cost, added cost and savings you're going to experience under the private option. There's going to be $26,866,297. I don't know how they got it that accurate, of added administrative cost to do the private option. So that adds to that $1.9 billion. But then you see this line item, other transition Medicaid programs. Dr. Thompson alluded to this. They're talking about breast and cervical cancer,
TB,
tuberculosis, and some family planning services. They're saying those people that are on Medicaid could transition into the private option, and that's going to save the state $33 million a year. And then he talked about the uncompensated care. When people go to the emergency room and they don't pay for it, somebody's picking up the bill to pay for the hospitals. And they're saying that $361,500,000 over 10 years are going to be saved in uncompensated care. The next thing that they counted as a benefit to the private option is a premium tax. When you pay, the way the Affordable Care Act is set up is when the subsidies are paid or the premiums are paid for the health insurance plans on the exchange, there's a fee of 2.5% that's paid on those premiums that goes to the state. So there's $436 million of fees or taxes that the state's going to get off of the premiums that are paid. And that, from an accounting standpoint, that's a benefit to the state of $436 million over 10 years. And finally, they use something called a macroeconomic impact. And that's simply saying that if you spend $20.5 billion on health care in the state, it's going to go to people's salaries, there's going to be sales tax paid on that, and you're going to generate $715 million of new income to the state off of the taxes that are paid on that $20 billion investment, and that's what they're calling a macroeconomic impact. You add all of that up, and you see that $1.9 billion per year cost to the state, the net benefit, or the net cost, is $439 million instead of $1.9 billion over 10 years. And you still got the cost on the status quo and the expansion of $1.1 billion or $2 billion. So you've heard how the private option is going to save $670 million over 10 years for the state. That's how they calculated that number. They subtract the $439,613,851 from the $1,109,857,441. That's where that $670 million savings comes in. That's the effect on the state. The next line is what the actuaries said the cost to the federal government is going to be. They said on the status quo it's $2.6 billion over 10 years. To expand like President Obama wanted to, it's $21 billion over 10 years. And to do the private option, it's $20,482,000,000, $20.5 billion cost to the federal government over 10 years. If you look at the total spending, state and federal, it's $3.7 billion for the status quo and $20.9 billion to do the private option, which is better than the $23 billion to do it like President Obama wanted to do it. Now, there's been since this actuary report came out, there's been a lot of additional number crunching done, and I agree with some of those numbers. I think that cost on the status quo instead of $3.7 billion, I think that's low because they left out some things, and I could see how that number could be up to $5, even $10 billion on that side to do nothing. But you've still got the $20.9 billion cost to implement the private option. And you might get the margin between those down to, if you be real generous, you might get it down to $5 or $6 billion, but it's probably going to be somewhere in the neighborhood of $10 billion between the total cost difference to do the private option and to not expand. And we've heard it called free money from Washington, D.C., but it comes from somewhere for that money to be spent. The next thing down on the bottom left-hand corner is we keep hearing about all the money that's going to leave the state. And regardless of what we do and the decision we make in Little Rock, because of the federal government's decision, there's money that's going to leave the state because of the cut in dish payments to hospitals. But I will say President Obama's budget right now remove those cuts to dish payments. Now, him getting his budget approved and what happens is one thing, but he did take out the cuts in dish payments to hospitals. You've got the cuts in Medicare that are going to affect hospitals. The hospitals agreed to this under the Affordable Care Act because they thought they were going to make that up under Medicaid expansion, but then the Supreme Court said, well, the states don't have to expand Medicaid, so they're kind of in a bit of a pickle on that one. And then you've got this employer. If you got 50+ employees, full-time employees, and you don't offer insurance, you can pay a penalty, and that's where this $38 million of cost to the small business comes in, and that's. That number is estimated between, I believe, 25 and 38 billion. I use the higher number, but say there's $1.2 billion per year that's going to leave the state because of the Affordable Care Act. But what you got to look at is how much is coming back into the state, because remember, all those people above 138 to 400% are going to be able to get government subsidized premiums on the health care exchange. If we don't expand, those between 100 and 138% poverty are going to get heavily subsidized premiums on the health insurance exchange. And then you got this woodwork population of Medicaid that's going to get additional federal dollars coming back in. So there's a RAND report, I've got a few copies of it, that said that the money coming back into the state for these 138 to 400% of the poverty levels is $850 million a year. The next line item, That one's up for debate because we can't get a solid number on how many are between 100 and 138%. If you use my 110,000 figure, you got 110,000 people. The actuary report says the per member per month cost on the premium is $437. And so you multiply the 437 times 12 months, that's how much it's going to cost per year to buy those premiums, times 110,000 people, and that's $718 million per year. That's got to come back into the state to pay for those premiums. And then you've got the 0 to 17% that are going to be put on the Medicaid, according to the actuaries, and the average number over 10 years from the actuarial analysis is $261 million. You add all of that up, and that's $1.8 billion that's coming back into the state to help fund health care. That's money that goes into insurance premiums, that it eventually ends up in providers' hands. So that's $611 million more than what's going to be flowing out. And there's still uncertainty about where those actual numbers are. I worked, and I even put my name on the private option bill, and I told my colleagues, I'm going to continue working on this, trying to find a solution that I think is best for the state and is best for the those that are needing health care, best for our long-term financial position in Arkansas. There's been a push to get this all resolved by the end of the session, which is next Friday. Well, last week when they said we're going to vote on it next week, I said, okay, I can't come to a good solution. My job is an engineer, and I'm always trying to work for a solution. They teach you in engineering school the problem-solving method, problem, plan, arithmetic, and answer. We knew what the problem was. We put a plan together. We've been doing the arithmetic. The answer we got right now is I don't like it. It's not the best, in my opinion, the best option. That's not to say that with some time something couldn't be worked out to make it better. And I filed another bill this week that takes the private option and puts it on steroids. Now, I've been told that the federal government won't approve that, and it creates a scenario where instead of just giving people these really nice health plans funded with federal money, you give them a lower cost health plan, and you give them a health savings account that you still fund it with federal money, but you end up saving about $150 per month off of that $437 per month. They have a $1,000 deductible. They take their money in their health savings account and they use it to pay deductibles and co-pays. And if they've got money left over at the end of the year, they could use that for education or workforce training to help them move out of poverty and into or off of a government entitlement program so that they could be a contributor rather than a taker from the tax pool.
I want to interject right here. As I understand your plan, what you're suggesting here is not the chronically ill population or people who are in long-term care. You're dealing with the able-bodied working poor.
Right, and it specifically says in the bill that Medicaid services, as we know them now, would be intended for what Medicaid was originally designed for, the aged, blind, and disabled. So if you were in those three categories, which are what are labeled high risk, you would still get Medicaid services just like they are now. But anybody else who would be on this plan would be put on a health plan more like what working people are on now. I work for an engineering firm. We have about 120 employees, one office in Hot Springs and one in North Carolina. And we've seen the effects of rising health care costs for years. And the plan that we've got right now is one that has a $2,000 deductible. It has a $10,000 stop loss, and it's got a lower premium, but it allows our company to put money into a health savings account so that we can pay our co-pays and our premiums off of this health savings account. That's really the kind of plan that we're talking about. I'm going to have a hard time going back to the employees in my company who are paying they're not only going to see a 50 to 100% increase in health premiums in the insurance they're paying for next year, but they're also going to see increase in taxes to pay for these other health plans. And then when they find out that somebody that's on one of these government health plans is going to have a very low deductible, if any, and they're going to have pretty much a Cadillac health care plan compared to the bare bones health plan that they're paying for, that's going to be hard for me to justify to them. And there are people in my company that would be below the level where they could actually get on the health insurance exchange. If I understand it right, a family of 4 could be up to $90,000 and still qualify for the health insurance exchange.
Joe was wanting to say something there.
I think Representative Wardlaw, and again, these guys, the whole team has been working, and it's been a pressure cooker. But your proposal, I mean, the Affordable Care Act is, for better or worse, and there are pieces of it that I find stupid. I mean, just plain stupid. But for better or worse, it is the congressional law that's 3 years old. The Supreme Court has said it is the law. And a lot of the description of the plan you're describing isn't going to be legal in 2014. And you're going to have to change some pieces. You may get grandfathered in. You may be able to get grandfathered in.
Mm-hmm.
But new plans aren't going to be able to have that health savings account model. I mean, they've made it illegal to have that as the vehicle. What we've been trying to do is figure out how do we make a silk purse out of a sow's ear with what it forces us to do. And I don't disagree that it does change fundamentally the ability of employers to kind of independently figure out how they want to structure their benefit program, which is part of the piece that I think most small employers, larger employers find the most attestable.
Can I
Yeah.
interject? The private option plan has presented the legislation that was passed in both the Senate and the House on Thursday. It has a pilot program for a health savings account. So if this private option is going to be implemented, they're going to have to allow a waiver so that we can run the pilot program on the health savings account.
And we hope in our discussions with the Secretary, I mean, that was a hard-fought piece, because the federal government in the law doesn't allow health savings accounts in the way that we've used them historically. So we fought for it to have a pilot project in the Medicaid program so we could prove to them it worked. They are not going to come in and let the whole program be a health savings account model. They've never let any state do that, and they were pretty clear, we'll let you do a pilot program, but you're going to have to show us that it works before you can expand it broader.
And I guess my position on that is, why would we do a pilot program if we weren't anticipating expanding that program in the future? It would just be a waste of money to do the pilot if we weren't going to. If the pilot comes back and says this is a good program, but by the way you can't do it, I don't know why we would.
Well, no, they're saying show us that it works. They don't believe it's going to work. Of course, in Washington, they don't have that much that works anyway inside. So,
right.
I mean,
and they didn't believe we could come up with a plan that was lower cost than fee-for-service Medicaid expansion, and we've shown them we can do that too.
no, I think we have their attention, and we have. I mean, candidly, we're 1% of the United States, so I think they're going to let us try some things, and we're kind of isolated. If we go bust, nobody in the rest of the nation is going to care. If we get it right, then we can really shine. And I think your proposals, that pilot is built in largely on what you've got in your proposed bill, so that we can show them.
And to do that program, and I follow exactly what Dr. Thompson's saying, you'd have to have probably a global waiver and maybe even a block grant from Health and Human Services to run a program like that. Rhode Island has been able to get one of those, and they've made some very substantial improvements to their Medicaid program because they got a block grant and a global waiver, and they were able to set up their Medicaid program to something that best suited their state without all the federal regulation on it.
They've come back, though, and asked to get out of that. Rhode Island has asked the Secretary to be released from the block grant.
And the global waiver?
Because it wasn't working.
And the global waiver?
Well, the waiver is a signed contract. They've got to figure out how they're going to get through the waiver piece.
Right.
So let me offer, and again, I think not to disagree at all, So Medicaid is this matching program that got set up at the same time as Medicare in 1965. The poorer states were intended to get more money than the richer states. Unfortunately, the richer states have had money to put their match up and draw that federal money out. So the richer states are those that are offering care up at $35,000 a year. The poorer states are offering a lot less coverage. So I don't disagree that your bottom number here, that we would end up in the positive from the federal funds is right. I don't know if the number is right, but I think the direction is right. But that was the intent of the Medicaid program, is to help poorer states help their poorest people be able to get health care. What's happened over the last 40 years is even poor states haven't been able to use it because we hadn't had money to put up. The state in Arkansas puts up 30 cents on every dollar, and the federal government puts up 70 to make a whole dollar, so we have a set 30-70 match. Maryland, one of the richer states, has a 50-50 match. They put up 50 cents. They get 50 cents from the federal government. The reason in my mind, and I've worked for a Republican administration, and I've worked for a very conservative Democratic administration. The reason I can get okay with this is we don't have, and are never going to have, federal tax dollars to build a high-speed rail train, which the East Coast does. We're not going to have a space center like Florida. We're not going to have a lot of these big federal programs like other states take our tax dollars and build in those states. This is us taking our tax dollars, bringing it back for our people, instead of letting it go to other states that are expanding Medicaid. I don't like that we're out of control on the Affordable Care Act, but I do think it's our responsibility to try to make the best we can until it's changed.
Yeah, and I've had people encourage me, don't look at this with the federal government in mind. Think about Arkansas. This will benefit Arkansas. I'm not totally convinced it will be a benefit to Arkansas, but you can't look at Arkansas like we're in a vacuum, because if we were in a vacuum, the $20 billion to run this program wouldn't be available. If you look at the $670 million projected savings, it's going to take $27 of federal money to generate $1 of state savings. And this is an argument that people have. It's the collective effect argument, that what one little state does, what Arkansas does, has no real significant impact on the federal budget. But if every state's thinking that, it does have an impact. And I consider $10 to $20 billion over 10 years a significant impact. Maybe not compared to the trillions of dollars that the overall program is going to cost, but I can't just put blinders on and say this is all about Arkansas, because I know that federal money that gets called free money is coming out of somebody's pocket, and if it's not coming out of somebody's pocket, it's coming from someplace else that it's being borrowed from, that's increasing the federal debt.
If I might just interject, I've heard several experts, and an expert's somebody that's more than 50 miles from home, so both these guys are experts today. They truly are, though. But I've heard several experts indicate that if all of the states were to go for what we are terming the do-nothing option, that the total federal savings would be around $1 trillion. I don't know that that's validated, and I'm certainly not going to posit that, but that number's been tossed around. What I kind of want to do is kind of nutshell this for everybody as I see it. What we're looking at here, and you guys correct me if I'm getting this wrong, we've got somewhere between 100 and 137,000 people that will be in what we call the donut hole. They're not going to have any sort of medical care insurance available to them if we were to do nothing. Is that fair?
I think the number's a little higher than that, because just one thing, 0 to 17% of poverty, you only get coverage if you're a parent of a child and you have those income limits. So if you're not a parent, you're not eligible in the 0 to 17. I think there's another 60,000 people that are 55, 60-year-old individuals who's been widowed or whatever, and they're in that space.
There also are some people in that space that also have intermittent coverage,
right,
and that give us the whole churning effect that becomes really problematic from an administrative cost standpoint. But, okay,
So somewhere between 140, 200,000 people, and that's, you know.
without question, there is a subset
Right.
of people that's somewhere in the $100,000 to $200,000 range, or 200,000 people, person
yeah.
range. That's generally.
Yeah, I've
generally-
heard numbers as low as 89,000, and
That's about the lowest number I've heard as well.
but the fact that we're this far along and we're sitting here debating how many people that is a concern to me.
It's very, very difficult to quantify. I think everybody agrees with that. That's one of the things that's made this very difficult for me is I'm kind of a hard numbers person, and there literally are almost no hard numbers in this process. We are dealing with abstract concepts almost totally. But let's go back and look at the cost side of it that Representative Westerman has talked a lot about, and I want to kind of give Dr. Thompson an opportunity to go back through this as well. The way I see it, looking at the numbers, let's start with the plan that President Obama originally, and that was largely pushed in Arkansas in the last election cycle, which is just straight line Medicaid expansion. The total federal cost, and I'm going to look at the federal cost for just a second first, is about $23 billion over 10 years, if it were to do that. So it's clear that this Arkansas plan that has been developed with a lot of cooperation costs about $3 billion less over the 20 years than the president's proposed plan. It's also clear that it costs substantially more than doing the do-nothing plan to the feds. But there's another side to that, and that's where this decision gets very, very difficult. The way that the ACA is written, the effect on Arkansas is exactly the opposite. Our Arkansas budget goes the opposite direction. We are facing a situation where, and I think Bruce's numbers here kind of indicate that the net Arkansas cost under the private option, $439 million. Sticking with the status quo, you got $1.1 billion. Now, you got to drop down to the bottom spreadsheet and look a little further to see that net federal revenue impact of $611.
And that 611 million is each year. So to put that on the same terms as up top, multiply it by 10, and you got $6 billion there.
So there's, there, you can even make a case that in the long term it may cost us less to not do anything. Keeping that in mind, you still have that subset of people out there. That's why I said this was a moral decision at some point. You've still got that subset of people out there who don't have access to health care. I think at least insured care. They're probably still going to fall in that uncompensated care when they really have to go get expensive care. So the decision that many of us are facing here is literally the numbers probably, again, they're not real firm numbers, but the numbers would indicate that you can make a case, I think pretty solidly, that doing nothing might be better for Arkansas. You can make a case that doing something might be better for Arkansas. I think it's clear that the president's proposal, as it was originally, it's clearly not the best, and that one's completely off the table at this point, I think, in the legislature. But there's a case that can be made on either side of this. What is absolutely clear is the moral component is sitting there, because you have people who are going to be in that donut hole who aren't going to have access to insured care. That's the question as I see it. I'd like to hear some feedback from both you guys on the way I've kind of nutshelled it and how y'all see it.
Yeah, I think the discussion is reflective of the discussion that's been going on in Little Rock, and I think it's a great discussion. The Affordable Care Act, and again, the Congressional Budget Office, which is supposed to be the independent, nonpartisan entity, scored originally the Affordable Care Act as neutral. The amount of taxes and fees and money they were going to extract was going to pay for the care. The Supreme Court, they went back and did it again, and it actually suggests that because states may not expand Medicaid, it may make the federal government money. And we've got information on our hospitals that you may want to ask Tim to share on your MENA hospital, that those taxes and Medicare fee reductions are happening that we're not backfilling. And so the Congressional Budget Office, after the Supreme Court came back and revised their budget, saying that no, that it actually might make the federal government money if states don't expand Medicaid because they won't have that cost. Now, I don't disagree with Representative Wardlaw's, not Westerman, sorry. I'm sorry about that.
He doesn't farm- he doesn't farm
I was in the room all day yesterday with.
He might take offense to that.
No, he won't. I mean, the
Yeah, Yale is right.
Medicaid program, just let me say this, is intentionally supposed to help poorer states. What we don't have numbers on, and this is, I think, important, you're correct. The sliding scale on the insurance exchange for a family of 4 will go up to 400% of the poverty level. Poverty level for a family of 4 is about $17,000 a year. So 4 times 17 is 4 times 7 is 28, 78, 68. Somewhere it's high salary range. In states that have a higher family income, median family income, they're going to get a lot more tax credits. They're going to get a lot more help for people buying up in that high income range. We don't have that many families making $70,000 a year. So that's why you do have a higher number on the Medicaid support, because we have a lot more poorer families. Other states like Maryland are going to get a lot more tax credit support, and they're going to be on the other end of the teeter-totter. So CBO, when they passed it, said it's net neutral to the Congress. I don't know that I believe that, because I think they probably scored the inflation wrong over time. Anything they've ever scored has never been exactly what it ever cost. But when the Supreme Court said states don't have to do Medicaid, the CBO came back and said it's going to save the federal tax dollars to the Treasury, because states aren't going to take advantage of this. And those that don't take advantage of it are disadvantaging themselves, because it was intended to be the complete package. Now, I don't disagree with you. We're going to get more Medicaid money than we're putting in, but other states are getting more tax credit money than we're going to get. And I think the balance is what we've got to make. You've got to make good decisions on next week.
At this point, I think I'd like to have Tim join us up here for a little bit and kind of talk about it, put it in MENA terms. There's Medicare cuts that were built into the Affordable Care Act, and he's got revenue impact numbers as how those are going to affect us locally. Those are going to happen regardless of what we do here in Arkansas.
Absolutely.
The question then becomes, how do the responses that we make impact what happens here? So if you want to
I
go
appreciate
through
it,
that.
Nate, and I was looking to interject. As Nate talked about and they've spoke about, just looking at the existing cuts, the cuts that are already in place over the next 10 years affecting our hospital, not other hospitals.
This tan sheet has that information on it in
Yeah.
an overview. It's not the local information.
Yeah, I've got the local information. I'll be glad to, if anybody actually wants to see it, I'll be glad to provide it to them as well. But on our hospital, just the cuts alone that we're going to be faced with through the accountable care, ACA cuts, the sequester cuts, bad debt cuts, coding adjustments, the total impact for our hospital will be $9 million over the next 10 years. As they spoke about, hospitals were okay with this because we initially thought that the Medicaid expansion was going to happen, and that was going to help offset some of this. So if we do nothing, we're going to be faced with $9 million over the next 10 years that we're going to have to look to make adjustments to offset those cuts. If the expansion is approved, the net impact, the gain to our hospital will be about $818,000 is what they're estimating per year. So even over the 10 years, we're still going to see a net loss, but it's not going to be $9 million. It'll be somewhere closer to $1 million over 10 years of total Medicare cuts that we're going to be faced with.
Thank you. I appreciate that.
Absolutely.
Does anybody have any questions for Tim? If not, we'll kind of. Yeah.
Does your analysis factor in the people that are going to be on the health insurance exchange and the fewer uninsured people that are going to be coming in?
Well, it's the analysis done by the Arkansas Hospital Association, which that's kind of our folks that we have that do our research and put together kind of our numbers and stuff. So I'm not sure if they do or not.
I spent about well over an hour discussing this issue with Jody Ann Trett, who represents you all, and it was my understanding from that conversation that those numbers didn't reflect that in its entirety.
If you just look at it from a macro level, you're going from 550 to 600,000 people without coverage down to even say 200,000 people. You got 400,000 more people that are, when they go to the hospital or the doctor's office or all the other services that Medicaid covers, they're going to have a way to pay for it now. So
The challenge, though, and Tim, correct me, the younger people that are getting that health insurance don't go to the hospital that much. The older people that are on Medicare go a lot more, and they've had a reduction in payment for the most common hospitalized patient that they have. So it's not just a one-for-one trade-off.
No. I mean, that's the majority of our patients is the, the elderly. Medicare for us is 50% of our patients at our hospital is Medicare.
yeah, but Rand said that number is 1.2 billion for the state.
You can use a copy of your REN study.
Yeah.
You may not have that too. One of the concerns that I have relative to this overall is all of the assumptions that we're dealing with in these numbers assume that the private insurance companies maintain their current reimbursement rates. And I think that's a really difficult thing to assume in the long term. In fact, I think it probably doesn't remain that way. Now, these pools and the larger pool that would come along with this, what we're calling the Arkansas plan here, clearly would give them a better risk pool. The question becomes, with the coverage requirements that come along with the ACA, does it affect their costs to the point that they have to lower reimbursements anyway? So I think that's one of the things I want you all to keep in mind as you consider this is this is all assumes that private insurance reimbursement rates remain static. And I would be very cautious to make that assumption in the long term.
I think the other thing, and again, this is, you are getting a feel for what the debate has been, and there's no right answer. I mean, it's just a decision that's got to be made. But before this option was really fleshed out and passed, as you said, the Arkansas Healthcare Independence Act was the name of the act, the insurance commissioner asked how many insurance plans would want to be on our health insurance exchange, and he got 4 letters. Last week, we won, and as most of y'all know, we have a pretty dominant single insurance carrier in the state, and we don't have a whole lot of competition, and so the market rates are somewhat non-competitive. And when you don't have competition, you don't have any downward pressure. So we had 4 that said they were interested. Well, last week when we had a meeting to explain what had been passed, this was on Thursday, we had 8 insurance carriers come into the state because suddenly instead of 200 or 300,000 folks, they were looking at 500,000 folks in the business, and that made them much more interested to think about coming in and opening up a new competitive insurance option. And I think, part of, and again, I want to go back, I mean, Representative Westerman is absolutely right. Our federal budget is in shambles. But what I hope our congressmen do is they don't try to balance the federal budget on the backs of people's health care needs. I want them to look at the hundreds of billions of dollars we're paying Afghanistan to be our friend and put that on there too and say, all right, where do we really want to put our federal dollar? Because I think we're spending money all over the world and we're not taking care of our own citizens, and this is an opportunity and I believe an obligation for us to do that first.
I think we're to the point that we've kind of laid it out there, I think, at least reasonably well. It's a very, very complex issue. As if you haven't figured that out by now, it's just, there are no right answers. I think all 3 of us at the table would agree. There is no right answer here. Well, Representative Westerman has the solution. Finally got past arithmetic and got the solution. Did you have something to add before we take questions?
I want to add just a couple more things. My wife says she thinks I dream about this at night. I don't know if I talk about it in my sleep, but I want to point out that premium tax. We're talking about the federal government, the $436 million benefit. If you think about the logic of that, under the private option, the federal government's going to pay the premium cost on insurance plans, and they're also going to pay a fee on that premium cost, and that $436 million is a 2.5% fee on those insurance premiums. If I'm in Congress and I'm looking at a place to save money on the budget, I'm going to look at that and say that's ridiculous that we're paying these fees or these plans, and then we're paying a fee on top of the plan. And you know, a sequester deal, anything could wipe that out like that. We talk about all the triggers that are in the legislation. If this doesn't go just like we want it to, the program stops. You can't write a trigger for what Congress may or may not do, and there's no trigger in the legislation to say that if they cut that premium tax, this plan stops. And if they cut that premium tax, that's $436 million that we were counting as a benefit that's no longer there. And then, you know, we also have to think through, in the long run, what does this look like? And sure, it could stop in 3 years, but if we put 287,000 people on a government program and the federal government doesn't follow through and the state says, okay, you didn't make the trigger, the program stops. I think about as a legislator being in Little Rock with 287,000 people that had a benefit that's going to be cut out, and what kind of pressure is going to be on you then to do something not to take that benefit away. And the thing to make that benefit not go away is probably going to be to raise taxes. That's ultimately probably the solution if we get into that scenario. So trying to think through what's going to happen in the long run, and there are a lot of what ifs, I get real uneasy about where this program could go.
And I think you're right. We've got circuit breakers and stops. In 3 years, the legislature has to decide they want to continue it. No question, it's hard to stop a program after it starts. The Affordable Care Act is for the next 10 years, passed by Congress. I'm not sure Congress can do much to do anything. I mean, you know, an act of Congress takes both sides, both houses, all to get to it.
They can't pass a budget.
Representative Westerman raised an important issue. The sequester. We hadn't talked about all the cuts we were talking about so far were Affordable Care Act cuts. The sequester cut farther on the Medicare payments. They took another 2% out of the Medicare payments. So it, and again, I hope you don't hear any tension really in this dialogue and discussion. It is trying to make the best thing out of a bad set of options, and that's what the 100 folks down there have to decide next week.
I do want to throw in that there's general agreement. These bills been passing with nearly unanimous support for major reforms to our existing Medicaid program, and that's something that we haven't discussed today. But we've one of the ones that I'm particularly proud of, and I think it is now in the Senate. We passed it off the House floor earlier in the week to establish the Office of Medicaid Inspector General.
Actually, that one's going to the governor.
That's signed by the Senate. Okay, so that's headed to law, and what that does, it moves the Program Integrity Unit out of DHS entirely and creates it within the executive branch. Tell us exactly where it's at.
Yeah,
I believe it was your bill, wasn't it?
Right. The Senator Sanders and I sponsored that bill, but it's it creates the Office of Medicaid Inspector General. We've got a Medicaid system that's already there. It's $5 billion per year program. If you add all the administrative costs and everything, and we're talking about a $5.8 billion per year program. To put that in perspective, the state budget is $4.8 billion. So our Medicaid program's bigger than our general revenue state budget already. Of course, most of that's federal money that's flowing back into the state. If we do the private option or Medicaid expansion, instead of a $5 billion program, it's going to be a $7 billion per year program. For every 1% of waste, fraud, and abuse in that program, at $5 billion, that's $50 million a year. If we go to $7 billion, that's $70 million per year. The GAO, Federal Government Accountability Office, estimated that there's around 10% of waste, fraud, and abuse in Medicaid. Some put that number closer to 20 or 30%. It's the responsibility of the Program Integrity Unit to audit and find where that waste, fraud, and abuse is. Some other states have very successfully, New York and Texas and about 9 more, created this Office of Inspector General. that pulls that program integrity unit out of DHS and puts it as a standalone entity that's shining the light on the transactions inside, and they report directly to the governor and they report directly to the legislature. So I'm excited that we're going to establish this office and hopefully capture some of that waste, fraud, and abuse that's going on in the existing Medicaid system.
You want to talk about some of the other
Yeah,
reforms that
there-
are advancing along with all of this overall?
We passed a law to allow ambulatory surgery centers to see Medicaid patients. Now, they can see them right now, but Medicaid pays so little that the doctors always send them to the hospital to do what could be done in an outpatient environment. If you compare the cost to do an outpatient in the hospital, it's anywhere from 5 to 10 times more if somebody gets a service in the hospital than in an outpatient clinic. Also, the chance of getting an infection or having further complications or morbidity is higher in the hospital. So it makes sense, if you want to save cost in Medicaid, set up a structure so those patients can go and get outpatient services. And we got that law passed. That's one thing that Rhode Island did that was successful. We've got a bill that would be a pilot program to create an electronic ID card for Medicaid beneficiaries. The reason, and it's not necessarily cut out fraud with the beneficiaries, but it's to attack the fraud on the provider side. There are several other bills that I could talk about, but I'm guessing people want to ask questions.
And let me just commend on the Inspector General. I think that's going to be something that we've never had that's going to be good. They combined with, and again, by shrinking the Medicaid program by a couple of 100,000 folks and putting them into the private insurance companies, I don't think we're worried about the private insurance companies. They're going to root out waste, fraud, and abuse because that's how they're going to make their margin. We hadn't had the same issue on DHS, and so the private option actually pairs the Inspector General with the private sector on trying to squeeze waste, fraud, and abuse. And so I think that's really, I see them as going hand in hand. I know now one hand you're not quite as supportive of, but I'd like both hands.
Well, and I would agree that that's a valid argument. That if when you get people out of Medicaid and you got a private insurance company managing it, and that's where their margin is, they're going to try to squeeze out as much waste, fraud, and abuse as they can.
I think one of the things that's frustrating to all of us is I think if we had another month before this legislative session ended, we probably wouldn't be having the conversation that we're having today and having to make a tough choice. I think we would probably be to the point that we would have something that we could all say, hey, we're all clearly for this. There's a lot of little minor questions. Just a second, Joe.
Sure.
I think the problem that we have from a legislator's standpoint is if we leave the session and don't have this complete, we have a budget year that's about to end. There are a lot of decision points that are coming up relative to ACA where decisions have to be made, bids have to be taken. There are so many things that the clock is ticking. The other side, I'm going to speak just purely from a legislator standpoint. If we leave the regular session and opt for a special session, the governor controls every aspect of that process. He can tell us what bills we can consider. He can tell us what ideas we can consider. We are totally in the hand of the governor at that point, and it's almost out of the legislature's hands, other than to vote yes or no.
Which is Trump.
Which is that clearly is a trump card, but we lose much of the ability to offer options, and that's the concern that many of us have as legislators is. Do we really want to hand the governor complete control of this? And I frankly, for one, don't. Many of you know he came over here and campaigned for a completely different set of values than I have, and frankly, I would much prefer not to have that completely within his control. Joe, you were itching to talk, so.
Well, I might not be itching now let me stay out of the politics and just give something that's concrete. The Affordable Care Act requires that the private health plans start enrolling people in October. So let me just back up from there. That means that in August and September, they have to be getting their information out so people can start signing up. Which means that in July, the insurance commissioner has to approve which plans, which means in May and June, the plans have to submit their bids, if you will. And the insurance companies have to know whether this 250,000 people is in, which would change their bid, or whether it's out. So independent of the political process and special session and legislators, we're getting perilously close to, if we want to do the private option, we're going to make the private sector not be able to work to start in 2014. Now, we could delay and start in 2015, but what that does is the Affordable Care Act says the federal government will only pay 100% the first 3 years, which is what the limit of the bill is. So we lose 1 full year of that federal funding. And that's, I mean, that's the time pressure on the sequence. There's both a legislative pressure. We will have to get agreement from CMS in the next 2 months to then be able to tell the plans, yes, it's on the insurance side, and I've had to learn more about insurance. We've all probably learned more than we ever want to know about how this stuff works. But this is like putting a big self-insured 200, 250, whatever the number is, 1,000 people into the individual market. It stabilizes that individual market because essentially the federal government through the state is making the pool bigger.
I'm gonna stop it right
Yep.
there because we've talked for an hour and a
Too much.
half, and I promised Rudy that we wouldn't run his 3-hour battery down, and that we'd try to get out of here in under 2 hours. I'm gonna pitch it out there now and let you all start talking, and we'll try to shut it down around 12:30. Let's just start throwing questions, and we'll do our best to respond. Gar, you're waving your arm.
First of all, thank you, Dr. Thompson, Representative Westerman, for coming over. I have real concerns about our hospital and the effect this not taking this private option, or best worst thing, as I like to refer to it. We do a lot of economic development here. I'm involved in a lot of things, trying to improve the situation here in our region. And without that hospital, nothing else matters. And a weakened hospital is a dangerous situation. And I saw you this morning on TV, and this deadline thing is kind of critical. We're going to have to move if we're going to do it to get these insurance bids in pretty quickly. So we don't really have the luxury of waiting either. So I just don't really see us not taking this private option. So thank you.
One thing I want to note, following Gar, and I think you're basically restating what we all feel, and I appreciate the feedback as to how you personally feel about it, because that's why I'm here today. I want to hear from y'all about what you've heard basically what we know. Now tell me what you want me to go do. This decision, the bill has passed. The question is, will we fund it? And the legislation specifically says that it's invalid if it's not funded. That vote is very likely to be a 1-vote margin either way. I mean, it is highly likely that I could be the deciding vote. And I represent you all. I don't represent my views. Frankly, I have to tell you that today, if I had to cast a vote, I probably would vote no. But it's a very, very slight lean that way. It is easily the most difficult decision I've ever had to make. I want to say that just before I forget, all the materials that we've talked about today here and that I've handed you guys, I have available electronically, so you can take them, share them with your friends, neighbors, whatever you'd like to do. If you want those electronically, send me an email at nate.bell@arkansashouse.org and request it, and I'll get that out to you. Joe, you're waving your hand.
Yes, I agree with everything that Gar said, and I'm in favor of the private option as well. Thank you.
Thanks. Philip.
Gentlemen, thank you for coming up. As Gar eloquently stated, every day I go to work at the college. I happen to be the president of the college. We're focused on economic development. I can remember years ago when we fought for that tax get the hospital up on its ears, off its ears. He's faced with cuts, I'm faced with cuts. What we're doing in this county through the medical field is quite phenomenal. We are an aging community. People that are moving into our community right now, and I've got data to support this, are of the elderly population. We can go down to Wolf Pen, we can go down to Shady. What's it lined with? A lot of gray hair. That's great. We've got to support them. This institution is critical to us, it's critical to U.S. Motors, it's critical to every private business. Losing dollars, which he's even with all the data, he's still losing money. But how much can he take in the loss? $1 million over 10 is a lot better than some of the other options. I know you're challenged with this decision. I can see in your face. But the reality for us here locally is that, maybe that's a bad deal. We can't fight the federal side of it right now.
They're all bad deals.
They're all bad deals. But you know what? In this community alone, our ruralness makes us unique. And it's even more of a challenge. We have to fight harder every day for economic development. Him suffering is a kick in the teeth to all of us.
Thank you. Anybody else? Questions, comments?
I have a question. Do we have any guarantee that the secretary is going to accept the private option at the federal level?
So let me speak to that, and I was in the room with the governor and the secretary's team in the February 22nd meeting, and I have been in the room with the phone calls that have happened since then. The way these things work, it's the same way that happened with the AR Health Networks. We have given them a concept paper, and they have said, we are absolutely not going to do this. We said, well, we need the pilot project on health savings accounts. They said, can't do it all that way, but we don't believe it'll work, but we'll let you try it with a few hundred folks. So we have a concept paper. We have a letter from the secretary saying that she supports that concept. We have a bill that has been passed now by both the House and the Senate, and the governor's not going to sign it until the appropriation says it would go into effect. I don't want to speak for the governor, but I can't imagine him signing it until y'all decide on whether you want to fund it or not. The process would be, if the legislature then decides that this is something that if the secretary approves, Medicaid will put a waiver, it's like a contract, with the federal government and says, here's what we're going to do with your money. We're not going to do traditional Medicaid. We're going to follow this bill. We're going to buy private health insurance. We're going to have a pilot project on health savings accounts. So the sequence is, we gave the secretary a concept. She said the concept is good. Now we've turned to the legislature. Actually, the legislature came up with a concept that we took, so I should back up. Leadership, Representative Westerman and others on the Senate side came up with a concept. We took it. They said yes. We came back. Bills passed. Whether funding is allowed or not is the question on the table. If funding is allowed, then we go back. It's technically called a waiver, but it's essentially a contract between the state executive branch and the federal executive branch to say what we would do and how we would do the money.
And I'm not sure how many of you saw yesterday, Congressman Griffin's on the Ways and Means Committee, and Kathleen Sebelius, the Health and Human Services Secretary, was before that committee. And with everything going on here, he thought that would be an opportune time to maybe get an answer from her. And surprisingly, he held up the bill from Arkansas and said, have you read this? And her answer was, no, sir. And then he said, well, are you going to approve it? And her answer was, no, sir. But she did explain that she doesn't really work directly with legislators. She works with the administration, and she was sure her staff was looking at it. So that didn't make me feel overly confident. The letter we've gotten from Kathleen Sebelius is 2 paragraphs, and it references a 2-page memo that wasn't even addressed to Arkansas that on some of the concerns in the conceptual plan. So I've got a lot of faith in our folks on the state level, but I don't have a whole lot of faith in the people in Washington, D.C. in helping us implement this and make it work out for our best interest. And I think it needs time to be vetted more for some of these numbers to be looked at. If you talk about the bidding the insurance premiums, why couldn't they bid it with and without the private option? And get those numbers back, because they're critical in that actuarial analysis. If those numbers are off a little bit, when it goes into the multiplier, it makes a big difference. They may be better. They may show that this program costs a whole lot less, but we don't know that, and we're being asked to approve a $2 billion per year program on a very limited amount of information. The legislation is 2 weeks old. The whole idea that's been made public is about a month old, maybe a little over a month old. So I've been saying all along, let's slow down and do this properly. And the argument's been made, well, you're going to lose that money the first year. Well, by the same token, I can say, and we're not going to spend that money the first year too. So there's two sides to every part of that.
And I think it's important, I don't disagree at all that this is moving fast. But in the same RAND report that you alluded to, they project 2,300 people will lose their lives, or 2,300 people will be saved by full implementation of the Affordable Care Act. 1,100 people will lose their lives if you don't expand Medicaid. RAND report's language, if we don't do the private option. That's 11 people in your district, that's 11 people in your district each year that lose their lives because we didn't take care of them when we had the opportunity.
If you don't do this now, you'll have to wait 2 years for general session to do it then, or to handle it in a different way then.
Well, you can still pass legislation in the fiscal session. It takes a 2/3 vote resolution to pass anything that's not a fiscal bill, but you can pass legislation in the fiscal session.
So
And
it takes 3/4 to pass it anyway, right?
Right.
Right.
I think this, in fairness, I think this could be brought up in the fiscal session quite easily. There's more than sufficient support to, at least at this point, to pass a resolution to consider it during the fiscal session. That would not be a problem.
In business, I know that we always have a thing, if you have to have an answer now, the answer is no, if you don't know exactly what you're doing or where you stand.
Another idea I've proposed is to go ahead and, we'd have to do another bill because these bills have already passed, but put an implementation date of July 1st, 2014, which you lose that first part of the federal money. In the same token, you're not spending that federal money. And that would give this, and you fund DHS so that they can develop this plan and work the bugs out of it and come up with some ideas that we may not have even thought about
Yeah,
now.
I read the bill before I came here, and it doesn't say anything about what we've talked
Is it
about.
six
It's
pages?
9 pages,
Yeah.
but the first 3 pages about what it aims to do.
There's not a whole lot of
There's
detail
not much
in it.
specifics in the bill.
Tim, I want to actually ask you a question
Okay.
before you do this, because that idea has actually rattled around a lot of altering the implementation date. How negative would the effect be on
Well,
you if we did something?
That was my response. That's great if we prolong it, if we could prolong the cuts that we're facing right now until then.
Which
I mean,
we
that just-
can't, which we can't do.
I mean,
Yeah.
yeah, they're in place, so, those
Well,
cuts
now I
are.
am hearing those dish cuts may not happen because the president's proposed that,
But the
and
sequester cuts alone for
Yeah.
our hospital, I mean, that's a financial impact alone it's gonna be a huge cost, for us just to make the adjustments to offset it.
What, did you have a profit of any kind, operating profit?
Last year,
Uh-huh.
we did. We had an operating profit last year of 1.2 million. Of the 1.2 million, around 750,000 of that was meaningful use money that's set aside for the electronic health records. So straight through operating was about 400,000. The 2% cut in our Medicare through the sequester cuts is going to hit us for about 350,000 a year. So we're basically at break even just with the sequester cuts, because the meaningful use money goes away in 2 years.
Okay.
Bill's been waving his hand back here, so,
Well, I sincerely appreciate the efforts that all of you are putting into this. You just say that right up front. And you're far more in your study than I am. So I'm not, my question, there's 2 things that I've been wondering about. And right now, we're talking about now or not. What options are they if you say yes to this bill next week, you know, legislation can change, Congress can change. What options are you tied into that cannot be changed if you take this option that's before us now?
Bruce, you know it better than I do. I'm gonna defer to you on that one.
Well, of course, legislation can be changed with any legislature. If this gets funded and gets implemented, I don't think there would be any legislation changed in the fiscal session other than maybe the appropriation for it the next year. But if this gets funded, January 1st, 2014, this program goes into effect and people are going to be signed up on it. It's written in the legislation, the program could stop at any time, but it's going to be really difficult once you get all these people signed up on this program, if it's 6 months, a year, or 2 years, to stop the program. And what are you going to do with all these people, and how's that going to affect hospitals and providers if you just suddenly stop the program? So, you know, in reality, the program's not going to be stopped. If it gets funded next week, it's going to be, I think President Reagan said, the closest thing to eternity is a government entitlement program. That's what we're voting on next week.
And on that issue there, Social Security, every major thing that's happened, we've had these same debates and the fears and so on, but when you move into them step by step, you improve them. To not to move into them is to do away with the whole thing. While we're talking about this hard decision, people are going to be.
Medicare or Social Security.
I don't see any improvement in any of those.
And that's a good point. You're always in bad shape, according to how you look at things. But let's get back to this point. People, as pointed out here, that don't have health insurance, and you point out people are going to be dying if they're going to be dying either way, but it's going to really affect people.
In fairness, that number he quoted actually is pre-ACA entirely, so we're dealing with the subset population.
The 2,300 is pre-ACA.
Right.
The Medicaid expansion would represent about 1,100 out of those deaths.
Right, so,
And then
I
part
mean,
of
we're
that
still talking about
Medicaid
real
population-
lives, and I'm not trying to minimize it, but it is substantially less than.
I understand, that's just a number up or down, I understand that, but reality is, as you pointed out.
And you gotta compare that to the
Could I
lives
finish,
spent
please?
paying the taxes.
Could I-
Well, I didn't know if you ever were going to.
I'm going to, if you'll just give me time. If the decision is gonna be hard to make, whether it's now or next year or year after next, it's a hard decision, and I'm glad you're making it. It's gonna be hard, but putting off the whole thing, we're back to what we're talking about here, and I think our hospital in the rural areas needs something to happen. We over here needs something to happen to protect us. And I'm finished, and thank you, and let Mark have the floor. I know we've got to
But when you talk about saving lives, you also have to look at the other side. How many lives are spent working, paying the taxes to save some lives? You know, if everybody spends an extra 400 hours a year working, you add those up to lifetimes, you know, it has to boil down to.
There's a human impact and there's a business impact on every side of this. And that's, you know, one of the things that has upset me is with a lot of the rhetoric that follows around this thing, is there have been people out there basically saying that not doing this or doing this are gonna kill people. Well, the reality is people are gonna die regardless of what we do. And clearly what we do has some impact on
And something
choosing who that might be.
Something that makes sense as much as having those accounts to where, you know, I know people work hard and they pay for their own insurance, and then they pay taxes to pay for other people's health insurance. And the other people's health insurance has no deductibles, and it's a much more attractive. I know I have health insurance of my own. I have a $10,000 deductible. You know, now I also have to pay taxes to pay for somebody to have their insurance, and I hope, you know, I don't mind that so much, but I'd kind of hate for them to have a lot better insurance than I've got.
Draw everybody's attention back to this because it's in your packet. If you, and when you talk about human impact, this was sent to somebody in this process. I think maybe Representative Collins, but Joe may know. And it's a guy that owns a chain of convenience stores, and he just took his business, put it on an Excel spreadsheet, and said, "Here's the impact of the various proposals to my bottom line." And one of the things that I told somebody the other day that I struggle with is, you look at the overall math set, the employer fines and penalties aren't that big of an impact on the overall fiscal picture. But they do have a huge impact on individual people's lives. In this district in particular, the vast majority of employees in the area that I represent are going to fall into this area that's affected. That 18% to 138% threshold covers a huge number of the people in this region. So when I look at that, I look at, okay, well, how does this affect employability? And this chart right here lays it out pretty well, okay? Employers under the private option proposal are for people in that subset are largely exempted from the fines and penalties.
Under the private option.
Under the private option. Assuming that you don't do that, those employers are going to be assessed those fines and penalties. Now, again, in the overall fiscal picture, as we're looking at it statewide, it's not that big a component of the set. But to the people who might lose their job because their employer is going to be assessed a fine, it's a big deal. If you're working somewhere for $7 to $12 an hour right now, the odds are you are going to be directly impacted by the choice that we make here with regards to your employer. They're either going to cut back based on being assessed the fines and penalties, they're going to cut back on hours, etc., or they're not. Now, either way, federal money is going to get spent. The question is how much federal money is going to get spent. And I think anybody that knows me, some people call me a nutty conservative. I have never, ever been even willing to consider massive expansions in spending. The problem is here is we have offsetting spending issues. Representative Westerman laid it out about as well as anybody. If we do the private option, there's going to be a lot more federal money spent than if we don't. Absolutely. The question becomes how much. That's what everybody's fighting over, but I think everybody agrees there's going to be a lot more spent. Joe, that's fair.
You can't cover people without spending money.
The money's going to get spent. We're creating a new entitlement. The question becomes, my job is to represent this district. We're going to be responsible for repaying our share of that. But at the same time, if we don't do this, I can promise you, real people are going to lose their jobs in this district because employers are going to cut back. That's the bottom line.
I'd be a little careful, and just both of y'all have said create a new entitlement. This is, the governor has a letter from the secretary saying we can stop anytime we want to. The Medicaid program, this is not in the entitlement section. Other parts, I do agree with Representative Westerman, it's hard to stop once you start.
I'll just say potato, because
Okay.
I don't believe, my personal view on this, and I think it's shared by a lot of folks from the ideological camp that I come from, once you offer someone a government benefit, they are not retracted. And history would bear that out.
You can call Studebaker a Jaguar, but it's not.
But we, in reality here, are adding 89 or 137 or 187,000, depending on whose numbers you use. We're adding that subset of people to a government program that they would not be eligible for if we did not take this action. The donut hole, folks. Tim, you got your hand back in here.
Yep. Well, I know you're looking for feedback and support. I can tell you, since you called this meeting yesterday, and I received until midnight last night, I was still getting emails and phone calls, and just from concerned citizens, from doctors, from staff, from board members, all want to know one question: how will this help our hospital? And that's one thing that as y'all went through, kind of talking that your thoughts, as you've reviewed the bill and worked on the bill, you talked about, you know, the thoughts on how's it going to impact the state and the federal, and how's it going to impact your business, and how's it going to impact your employees. The one thing I didn't hear was, how is it going to impact our hospital as you're going through that? And I mean, you can't look at the bill and not say that it's not going to benefit our hospital.
Absolutely.
And our hospital is much different than others in the state. You know, we're one of the only city-owned hospitals left in the state. We do not receive any local tax support. That again, by itself, we are one of the only hospitals independent in the state that does not receive any local or county tax support. So that's a big feat.
Now, in fairness, you have a lot in the past and paid off the note. And
We have.
Had a sunset.
They had sunset, but
Yeah,
that was even
yeah.
before my time, so it was
Yeah.
7+ years ago.
You had to have that to get started, though.
And a lot of people, well, I mean, that was after it had been hospital for a while.
But it
So-
went into trouble.
And a lot of people donated thousands and thousands of dollars, and they still can, or we could still pass a tax.
Well, exactly. I mean, you
But
can-
there's been a lot of local support for the hospital.
I think everybody talking about this agrees, doing this clearly has a positive fiscal impact on the hospital.
Yes.
I think that, and not doing it clearly has a negative fiscal impact on the hospital. I don't think there's any dispute about that at any level. I guess if I were getting to sit down right now and write my own piece of legislation and pass what I wanted, I would look for delayed implementation. I think this is probably something we do need to do. I think we need more details through the process. And I think the concept of let's go, essentially what we're looking at, this thing's going into effect in January of next year. If we assume with delayed implementation that we bump it to July of 2014 versus January of 2014 for implementation, where we have the fiscal session in between to look at funding it, you're going to deal with the cuts till next January one way or the other. You're essentially looking at 6 months difference in the difference. I
When
mean,
did your cut start, Tim?
April 1st. Well, some of them started in January, the sequester started in January.
but if we do this now, it really doesn't offset you until the plan goes into place. You're not going to see the additional money until following next January one way or the other. I guess that's, you know, is 6 months going to, if we were to do that? Now, that's not even an option right now.
Right.
But if we were to do something like that, does that become something that you couldn't work with, or what, you know?
I mean, and isn't the city pretty flush with money? Could they help? I mean, the city usually has quite a bit of money.
I'm not even, I mean, I don't know if that's even gonna be considered, but if it comes up, I'd just kinda like your feedback on,
Yeah.
you know, clearly you got a couple $100,000 in negative impact.
We're fighters, we're gonna work with whatever, but I'm just saying from the standpoint of us staying financially viable, us not having to go through and really look at, you know, our hospital is different in that, you know, we're able to offer a wide array of diverse services that typically your smaller hospitals don't have. Don't have
It's a good hospital.
Don't have mental health, orthopedic, and just all the specialists that come in and stuff, and then even these programs, they're not programs that are highly profitable for the hospital, but they're a benefit to the community. And as hospitals are going through and evaluating, and as cuts are being made, those programs like that are the ones that are going to suffer, the ones that we'll end up having to get rid of and stick to our core business, because, you know, we just can't fund it.
I promised everybody 12:30, and I wanna try to get this in wrap up. I see a question here, so.
You know, just to kind of get the feeling of one of my favorite Washington quotes is, we have to pass this bill and see what's in it. I'd rather hold off.
Yeah.
I'll say
Hold
that.
off, as you had recommended. Let's take a look at it for another 6 months. Gives you more time to think about it. It's not a rush decision. And let's think about not just hospital impact, what about citizens' impact? There's taxes associated with this. There's a lot of things that, well, as a person, I'm a little bit concerned. I can appreciate a lot of the comments while I was running my own business. One of the things that really bugged me was the fact that I was making too much money to be able to afford a healthcare system that was given to people that weren't working.
I've been
Yes.
in that position for many years as a business owner myself, and my employees always had better insurance than I did, so, Mr. McCool.
You talking about getting money from the federal government, and wherever the source of the money is still taxpayer dollars.
The source of that money is the same place it's always been, your wallet and my wallet.
That's right. And if you talk about corporate taxes or any other things that's passed on to private industry, it's gonna be a cost and increase in services.
I don't think there's a person in
The consumer
I don't think there's a
gets it in the
person in
end.
the state to dispute that with you. Bob?
A couple things come to my mind is that first off, nobody in this room really talked about the constitutionality of what we're talking about. One of the things being the state is contemplating paying a private industry to cover costs of its citizens' health care. I'm not certain that that's a constitutionally approved thing for us to do to begin with. Second of all, the point has been made that we're going to be saving 11 lives by doing this in our county. Well, every one of us was born with a debt that we have to pay and we can't avoid. So what we're really saying is you are delaying a death of 11 people. Now, is that quality of life death that's being delayed? I don't know. I'm guessing that those 11 people, some of them will probably, and I know it's hard to say this, might have been better off being allowed to go to the Lord. So we're making a new entitlement here. It sounds like to me, and the assumptions are so tenuous, it's hard to even understand, that we're going to be spending, by going to this private option, another $800 million over 10 years for private coverage of insurance, which we have no assurances are not going to go through the roof. Knowing private insurance, health insurance the way I do, paying it out of my own back pocket, that's not a set amount. That's going to continue to go up. Some people in here mentioned 50% more next year, 100% more next year. And there's no guarantees in this that I see anywhere that the private option is going to stay fixed, that if there's any limit, upper limit to where it can go. Also with the Obamacare taxes on our individual businesses, if they don't cover, they're going to be cutting people back. They're going to go down to the number of hours that they can hire somebody. That's going to throw more people into this 0 to 138% poverty level, which means there's going to be more people going to have to be covered than I think we've even identified in these studies. And I know you put a lot of work in it. I appreciate y'all doing this, but I agree with some folks who've mentioned in this. There's too many unknowns in this to create a new entitlement, tying us up for another $800 million over the next 10 years minimum, according to these figures. And I think it'll be much, much larger if we do create that new entitlement. Thank you very much.
Chris?
Number one, like the gentleman said, we're born to die. It's simple as that. I also feel like, just like Obamacare was shoved down our throat, that, from my understanding, they didn't even read what was in the bill. And now we're trying to rush through something that I feel that we need to take a little more time and try to figure it out a little better than, as opposed to trying to make a decision. I think we'd be better off to kind of delay it a little longer.
We've got about 5 minutes before I promised everybody we'd wrap up, and I want to do two things. First of all, I want to say thank you to all of you for taking your Saturday morning to come spend it doing what we've been doing for the last couple of months, and sometimes in 8 and 10 hour meetings. On Monday, I have to push a button. I get to push green or red, and I'm gonna do that on camera I asked for you all to come today to kind of give me some guidance on that. So I'm gonna ask y'all to do what I have to do on Monday. I'm gonna put you on the spot. If you had to vote on Monday, the ones of you that be for this, stick your hand in the air for me. if you would be for it.
Which,
What's known as the private option. If you'd be against it, put your hands in the air.
You got a tough decision.
I knew it was a tough decision. I appreciate everybody coming. I will do my best to get this back out, all this information back out to all of you. And if you email me and request it, we'll get you the packets of information that we've had in front of us. And if Joe has any more he wants to email me that I need to add to that, I'll do that. Once again, thank you for coming. I'll push red or green on Monday. I'm gonna spend a lot of prayer and a lot of thought and study over the weekend. I appreciate y'all.